Hi, my name's Scott Kopetz, a professor of GI medical oncologist at MD Anderson Cancer Center. Delighted to be able to participate in the year in review and really highlight advances in the management of metastatic colorectal cancer. So I hope to be able to share with you the real advances that we've made. So this does feel like an impactful year, and I think we're leaving the year with better outcomes from our patients than we came in. So the first, just to jump into an area that has been really kind of provocative and thought-provoking is this idea of transplant for liver-limited metastatic colorectal cancer. So there's been a series of smaller reports over the years that have commented on and shown outcomes of single-arm series of liver transplantation. But this was a large randomized study called the TransMet study that Renee Adam and the TransMet group led. And so we started off the year at ASCO with this really kind of convincing data. And so this was a randomized study. There were 157 patients. They had to be reviewed by a panel, this validation committee, to make sure that they indeed were felt to not be resectable by traditional single or two-stage hepatectomies, and not have tumor progression going into this. So really, these are kind of good biology patients, disease-controlled, liver-limited metastatic disease. There were 94 patients randomized, so heroic effort to get to that, and evenly distributed between the chemotherapy and a liver transplant. And chemotherapy in an intent to treat manner. And you can see of those that we're looking at small-ish numbers, but in the 30s number of patients included per protocol. And you can see there was some crossover as shown in the slides here. The primary endpoint was the 5-year overall survival, and as you can see, this is the intent to treat data, and what you can appreciate is a striking separation of the curves, favoring patients who were randomized to the liver transplant. And this was a hazard ratio of 0.37. You can see the p-value there. And I think strikingly, seeing a 5-year overall survival of 57% versus 13%, with the caveat that these were small numbers going in, and only a few that had made it to the 60-month time point. So what do we make of that? Well, this is a very impressive results, I would say, in highly selected patients, but I think, a study that was well executed. This was done in France, where there was a high priority that was that these patients were placed on the donor list. So because of the research component, they're really put to the top of the list for organs. And at the moment, that's not really where cancer patients fall in the U.S. So it is provocative, but maybe not directly applicable. However, one of the changes that we're seeing is this real increase in living-related donors. So the idea that it's not an unrelated donor as was done in the TransMet, but this idea that family members, related donors may donate part of their liver to the patient, and that may improve feasibility in the future. So there's studies ongoing, cohorts being done in the U.S. for this now to get better understanding of this. But I think really an area to watch, but is still very much research related at the moment. The next study is the Checkmate 8HW study. This is a game-changing study, and I'll share why I think so. This is a study that randomized patients with MSI-high metastatic disease that had not received prior treatment. And they were randomized in a 2-to-2-to-1 fashion, where the 1 out of every 5 patients received investigator's choice chemotherapy alone, no immunotherapy in the first line, and then randomized either to a PD-1 or a PD-1 CTLA-4, which are really the kind of the key question that we've had in the field. Now, I'll note as an aside that one of the interesting areas here is that there's still this bit of issue with MSI high testing, and I think this is demonstrating in this case that patients who had central MSI testing demonstrated MSI high or deficient mismatch repair. 16%, 1 in 6 patients did not have that confirmed centrally. So I think just a little bit of a caveat and to keep an eye on and think about those patients that have features of the immunohistochemistry that may not quite fit, but an area for development. But back to the study, this first report that came out was demonstrating the impact of the doublet, Nivo-Ipi, versus the chemotherapy. And that was a striking home run, of course, and this is following, of course, the Pembro data compared to chemotherapy. And what you can see is a really convincing 72% versus 14% 24-month progression-free survival. You can see a hazard ratio and p-value there. Now, the real question, though, has been, does CTLA-4 add anything to the PD-1? And that was answered then with the recent report of the Nivo-Ipi versus Nivo arm. And again, PFS is the primary here, and the randomization then is as shown, and the results is as shown here. And I think consistent with what was seen in these cross-trial, cross-arm comparisons out of, for example, Checkmate 142, what is seen here is a convincing improvement with the addition of those 4 cycles of the CTLA-4 with a hazard ratio of 0.62 and the p-value as you see there. This is amazingly an area where median progression-free survival probably isn't the best metric, but it's really looking at that tail, like with the 36-month progression-free survival rate at 68% versus 51%. So convincing benefit. This was published in Lancet just a few weeks ago. And my take on this is really the new standard of care for first-line patients. Now, the CTLA-4, again, just a few doses of it did have slightly higher rates. This is low-dose CTLA-4. But I think an important point is that these curves, this 68% and 51%, the vast majority of these patients are cured of their disease. So, the treatment has stopped. They have not progressed on the disease on scans, and the data really suggests that very few of these patients have any viable disease remain or will progress. So what we're looking at in these plateaus are cure rates for patients, and so this is likely improving cure rates in this situation. Now, I'll put some asterisks on that word cure. It's a big statement to throw out there, and we'll look for the longer term follow-up. But all the data that we've seen with prior cohorts really suggests that these plateaus are stable in the majority of patients. All right, shifting gears. Reminder of the Beacon study. This is a previously reported study looking at encorafenib and cetuximab, so cytotoxic chemotherapy as a comparison to an encorafenib and cetuximab in these BRAF V600E mutated patients. Second and third line study. The report here was looking at the translational endpoints and really trying to better understand what is the mechanism of resistance that we see in these patients. And this was reported out in Nature Medicine last year. Here, it's a busy slide, but pay attention to the red hashes. These are acquired alterations. And what you can see is in the doublet or the triple arm, which included MEK, which is not part of the standard of care. It didn't add anything to the efficacy. What you see is a higher rate of KRAS, NRAS mutations, MET amplifications, MEK mutations or MAP2K1 mutations that are present. And so these really are not seen in the control. So really the initial concepts here are that these mutations are occurring and may be contributing to resistance. Now, One of the key findings, though, when you start to look at these in more detail and actually ask how much, and you can estimate the percentage of the tumor that actually contains these mutations. And so some of the provocative data coming out of this was that when you are controlling for the amount of DNA being shed, you can estimate that less than 1 out of 100 cancer cells in the tumor are actually carrying these resistant clones at the time of clinical progression. So there's some discussion in the literature and the field now to say, well, are we really overestimating the contribution of these secondary mutations to clinical progression? And when we're dealing with something that's occurring in less than 1% of the tumor, is that really why the tumor is growing on the scans, or are these just happening in parallel? So we don't have answers, but I think some provocative data coming out of that. So the conclusions here, these are common after targeted therapy when given alone. We see this after EGFR or KRAS EGFR inhibitors as well. But again, the suggestion, these are very rare, 1 in 100 or less in the tumors, and they may not be driving resistance in the majority of patients. So more that we need to learn there. So another update in the BRAF field was the report of the Breakwater study. So this was a large multi-center phase 3 study, first-line BRAF V600E mutant metastatic colorectal cancer. This was a study that was executed under the FDA's Project Frontrunner. So this is the first study to report out through this mechanism. So the Project Frontrunner is the FDA's initiative to try to bring novel therapies into earlier lines. And what the FDA said is that we will provide an accelerated approval for the agent if you can show higher response rates and durability of response. And that we will then convert that to a full approval if you then meet your primary endpoint of the study, in this case, progression-free survival. And so this is designed to really accelerate innovation in the first-line setting and provide therapy to patients sooner. So this was the first study to report out that first result. So this is a randomized phase 3 that has a dual primary endpoint of progression-free survival and overall response rate per that FDA plan. And indeed, I'd say that the response rate was increased. It went from 40% to over 60% with durability. And as a result, the combination of EC and FOLFOX was FDA approved in December. In this interim analysis that was presented at GI ASCO, though, also showed that there was a really strong trend to improved overall survival. And you can see a hazard ratio of 0.47 and a p-value of 4.5 times 10 to the negative fifth at this really early look. So we're looking forward to being able to share more data at an upcoming meeting on the overall survival and the progression-free survival. I will say that a press release saying that the overall survival has been met, so this is a statistically significant difference. Now we'll be able to report more of that later. So the anticipation then is that the encorafenib, cetuximab, and FOLFOX, which has accelerated approval in the U.S. now, will turn into a full approval to follow. So what do we conclude here? I would say, with the caveat that I'm an author on that, so may be a bit biased, but that encorafenib, cetuximab, and FOLFOX is the new standard of care for first-line BRAF V600E mutated colorectal cancer. These, I will say that the degree of this benefit was greater than any of us had anticipated, and really was impressive magnitude. This was following the really strong safety lead-in data that had been presented in 60 patients earlier. And so I think really is a kind of compelling and follows some biology and, really nuanced understanding now of how tumors are adapting to MAP kinase therapy and adapting to cytotoxic therapy. And the idea that we may be, by combining not just 1 + 1 = 2, but really providing synergy that follows some of this biology of tumor plasticity. So more to come on this, but I think really compelling results. FOLFIRI hasn't been forgotten for those FOLFIRI aficionados in first line. There is a randomized EC plus FOLFIRI arm that will be reported out later that was enrolled after the Breakwater study completed. All right, what about HER2? So Mountaineer, to remind everyone, was the first study looking at tucatinib and trastuzumab dual HER2 inhibition. And this was second line and beyond. RAS wild type, so important point, RAS wild type colorectal cancer. And the tucatinib and trastuzumab are blocking signaling through HER2. And we'll come back to that and contrast that with the ADCs to HER2. But this is really blocking signaling, therefore requires a RAS wild type tumor, just like an EGFR inhibitor requires a RAS wild type for signaling. So the final analysis was reported there, response rates of 39%. And I think as you see the spaghetti plot on the right, really some impressive durability. And you can see a number of those out well past a year, some of them even into 2 years. And so I think just acknowledging that some of these responders can be really durable. And I think we'll continue to watch the tails of some of those amazing responses. So this is a standard of care for second line and beyond, as it has been already, and this just gives us reassurance that there's a subset that have a really long benefit. But again, RAS and BRAF wild type patients and HER2 amplified. So what about the Destiny CRC01? So this is now looking at trastuzumab deruxtecan. So this uses a topoisomerase payload with the trastuzumab antibody. But predominantly, we think this is working through the cytotoxic payload. Trastuzumab alone does not have much activity at all in colorectal. It really needs the doublet or combinations, but we think it's through the payload that is predominantly doing the heavy lifting. Now, what does that mean? Well, we're delivering a payload, and so patients can enroll and may be deriving benefit even if they have some mutations. We'll talk a little bit about that in the emerging data there. So Destiny CRC01 was looking at the first cohort here, and some updated response and biomarker data. What you can see is the responses of predominantly in the IHC 3+, the 2+-ish positives, maybe some activity, but not quite as high there was seen. Now, you'll notice that there were some RAS mutations, PIK3CA mutations, HER2 mutations kind of scattered throughout. So really no strong correlation with those mutation status. Now, one of the questions was, how are the tumors progressing? If this was a targeting therapy, maybe we would have expected these secondary mutations to appear, but we didn't see any, really no meaningful number of acquired MAP kinase alterations. And there's also discussion about, well, perhaps the tumor could lose its HER2. We see this in gastric cancer, for example, and others, but really that was not seen. It was not a very high rate of that. It was a modest number of patients that occurred. Now the CRC02 now is the randomized study. This was a dose optimization looking at two different doses. Here again, RAS mutated or wild type allowed in, IHC 3+ or 2+-ish positive. And the data was presented by Kamral Raghoff and published at Lancet Oncology. 37% response rate with the 5.4 milligrams per kilogram, slightly lower response rates and less favorable toxicity profile in the 6.4. So the 5.4 is really the recommended dose. Now you can see a scattering of the mutations there, and in general, you can see on the bottom that the RAS status local test here, really no difference statistically in the response rate by the mutation. But interestingly, very low rates of the 2+ ish positive. So you did not see a ton of activity there. Really, the activity was manifested predominantly in the 3+ population. So reiterating that this is not signaling, right? Signaling and ADC, so it's really an expression that's driving this. The more expression, the more payload that you get in. So what can we conclude about this? So again, trastuzumab deruxtecan remains a standard of care for second line and beyond HER2 AMP without regard for RAS or BRAF. Predominantly, resistance is not through loss of HER2 AMPs. There were some, but not a big mechanism, and acquired RAS mutations weren't seen. Because questions have come up, how do I sequence my HER2 therapy? And if I have mechanisms of resistance through one that may impact sensitivity to the other, maybe it matters in what order I do them. My conclusion of this is that we should do what's best for the patient, but we don't have to be wed to a certain sequence. What do? I tend to do more targeted first, followed by ADC second. And a lot of times that's to give a little bit of space between my cytotoxic payload, since I'm always a little concerned about giving a topoisomerase payload right after a patient's progressing on irinotecan, for example. And so having a little bit of time in between. That's a bit of a nuance. I think this data gives you the flexibility to really pick the sequence that you would take a patient through. All right, what about KRAS? KRAS mutations, common in colorectal, of course. We'd love to have inhibitors of all KRAS. Maybe we'll get there. We're not quite there yet, but where we have made progress is with the G12C. So remember that G12C is just a few percent of colorectal cancer. Unlike lung cancer, where it's a more common mutation, it's less common in colorectal, but absolutely seen. So the current data is with sotorasib and panitumumab, or adagrasib and cetuximab, and so we'll just review some of the update data on those two approved agents. So this is the CodeBreak 300 study. This was looking at sotorasib at 2 different dose levels versus the investigator choice. Prior data had suggested the response rate and the activity was higher with the 960 milligram daily dose compared to the 240. So that is the approved and recommended dose. And this was asking the question in a phase 3 study that was looking at progression-free survival, but looking at a key secondary of overall survival. So this was in patients who had prior 5-FU oxaliplatin irinotecan. So you'd think about traditionally a third line and beyond setting. And randomized to trifluridine, tipiracil, or regorafenib as the control arm. So the protocol specified final overall survival and intent to treat is as shown here. A little disappointing there wasn't more of survival benefit seen. You can see the hazard ratios there. We're trending in favor of the KRAS inhibitor. But remember, there was access to KRAS inhibitors on crossover, and about a third of patients in the control arm went on to get other KRAS inhibitors. And this, again, small numbers, as you can see, wasn't really powered for overall survival. But this was the update that we had received on this. But again, active regimen, good response and progression-free survival. The final is the adagrasib cetuximab. This is an update of the Crystal-1 study that led to FDA approval of this regimen. And you can see here in the study that continued to demonstrate a nice response rate, 34% by a blinded central review, 43% by investigators. Overall survival 16 months. This was not randomized, so we don't have a comparison. And really reiterating the benefit of this in this second or third plus line setting. There is a Crystal 10 study that has finished enrollment that is randomizing in the second line to adagrasib cetux versus a FOLFIRI-Bev or standard of care regimen. So we look forward to the randomized data there. But we can say at the moment that both adagrasib and cetuximab and sotorasib and panitumumab are standard of care options for KRAS G12C tumors that have previously been treated. The efficacy may differ between these, and we can look at the cross-trial comparison of response rates or progression-free survival. The divarasib data is also has shown some impressive efficacy for G12C and colorectal with an EGFR inhibitor. So I'd say that the final chapter has not been written on this, but that for the moment we have FDA-approved therapies that really give us some flexibility and certainly something to think about. I think most excitingly is the roadmap that this provides for the G12D inhibitors or perhaps the pan-RAS or pan-KRAS inhibitors that we'll be following. And stay tuned next year for the 2025 year in review, and hopefully we'll have some more data to share in that space as well. Thank you.
All right, awesome job. Just a couple of quick follow-up questions. One, getting back to the last thing you were talking about, these KRAS G12C situations with plus inhibitor plus EGFR. I'm just kind of curious, like how much you think it actually offers a patient. We spent so much time over the years talking about regorafenib and TAS-102, and I always wondered, do you really see a benefit? And I wonder the same thing here. I mean, have you seen patients have, it seemed to be, not just stable disease, but good responses to these therapies? And how much quality of life issues? I mean, if you randomize versus observation, what do you think you'd see?
Yeah, and so, and don't want that overall survival data to really kind of sour. That was, the data that was updated this year, but really we do. And I think that's a bit of the outliers. So these are tumors that are responding really well, and patients are feeling much better. The G12C inhibitors are really well tolerated. We do have the cetuximab rash, but that's no worse than you would if you're doing a single agent cetuximab. So certainly manageable in the majority of patients there. And we do have durable patients. We have patients that are on 2+ years with these inhibitors. So there are a subset that are getting really good activity. But the median duration of response is in that kind of 6 to 8 month range. And so acknowledging that, again, these are late line patients, but that most patients are finding, tumors are finding ways to progress despite the therapies. And so that really is the challenge of how do we do a better job of addressing that resistance. There are strategies to think about combining with immunotherapy. So there's a Stand Up to Cancer study ongoing in this space to look at, adagrasib, cetux, and a PD-1 inhibitor that looks we be waiting to see some data on, just given the role that RAS plays in immunosuppression. And then there are other strategies to think about understanding the mechanisms of resistance to these agents and thinking about how do we intervene.
That's really helpful. One final question. You referred to one of the trials of MSI-high to the fact that there were these 16% of people who were thought to be MSI-high based on the community testing that were found to be not MSI-high. Like, what's going on there?
Yeah. So, what we're seeing is that a number of these are, some immunohistochemistry tests gone bad, right? And so there are some subtleties, and sometimes if you don't have good controls, you'll misread some loss of protein expression on some of these mismatch repair proteins. Remembering, if you just have loss of 1 out of 4, then of course you call it an MSI-high tumor. So things to watch out for if you have isolated loss of, for example, PMS2. Most of those are kind of technical flukes and not true MSI highs. So there's been some discussion about whether MSI highs should really be confirmed through two methodologies, right? Through the IHC as a quick screen, but then, if there's anything that feels a little off, that's where looking at the NGS to see what the mutation burden looks like. Many NGSs are now calling MSI through callers. And so, I wouldn't be surprised if we don't see guidelines evolve over the next year or two to really encourage people to do kind of confirmation testing in some situations.
I was just kind of flashing on some of the cases I've heard over the last few years where somebody had MSI high disease and just did not flat out respond to an IO. And the doc was like, why? Why don't they respond? And I wonder if some of them are really not MSI high.
Our estimates could be as many as half of the non-responders are just misdiagnosed.
Wow. And that kind of ties into, in general, the role of IHC nowadays. It's always been kind of an issue out there. Any attempts using AI? I know AI has been used for pathology reading and radiology reading. Do you think that could be helpful?
Yeah, it certainly can. MSI is one of the easier histologic features, even on an H&E, to pick out. And so the first AI examples a lot of times were ability of AI to call MSI high off of an H&E, mostly because you get this really robust lymphocytic infiltrate. And so, that can be something that's detected by AI. So I do wonder if, better awareness, first of all, of kind of a quality control and the metrics, and when something would be a little questionable on the IHC would be one component. But I do wonder if additional diagnostics, whether a confirmatory NGS or if we get there in the future, the AI could really make a difference.
I'm glad you reminded me of that. I sort of forgot about that. I remember hearing stories about, the pathologist called me and said, is this an MSI patient because of the histology? Do you see that in general? Like, when you have a patient who's MSI high and you check their histology, is it usually that's the way it's read?
Yeah, so you can indeed, the sharp-eyed pathologist will sometimes note that. It is one that's not perfect, and so the absence of a call of a lymphocytic infiltrate shouldn't dissuade you from doing the IHC testing anyway. But yes, it certainly can be reassuring.